Welcome. My name is Jasmine Kamboj, and I'm a medical oncologist in the state of Minnesota and your host for the day. Empowering Oncologists is a podcast brought to you by OncoDaily, where we will focus on day-to-day concerns of an oncologist's being and workflow, with a vision to find sustainable solutions. We hope to share our stories of wins, losses, resilience, and inspire and empower our community because we fly higher and longer when we fly together. Before we dive in, a disclaimer. The views shared on this podcast are in individuals and in no way are contributions from any institution, organization, or guidelines. For our session today, we have Dr. Bishal Gyawali, who is a medical oncologist and an associate professor in medical oncology and public health services, and scientist in the Division of Cancer Care and Epidemiology in Queen's University, Kingston, Canada. He is a graduate from the LDP class of ASCO 2023-24, also known as the best LDP class ever, which is where we first connected. Vishal, thank you for being here and welcome.
Thank you very much, Jasmine. It's really interesting to listen to you so formal and eloquent. That was a good intro.
Because I'm always giggling otherwise, right? Beautiful. Vishal, tell us about your journey starting from Nepal to Japan, Canada, US. You've traveled the world.
I was born in Nepal. I did my medical school in Nepal. I became a doctor there. Then I wanted to be an oncologist. And at that time, there was no oncology training program in the country. So I necessarily had to look outside. And I guess the commonest route most of my colleagues took would be to do the USMLE and go to US. But I have seldom taken the most straightforward path. I took the path of going to Japan for my oncology training. I learned the language. I did a PhD there. And I returned back to my home country of Nepal, worked there in a public hospital for almost a year. Then I moved to Harvard for a fellowship in cancer policy at Brigham and Women's. And then I moved to Kingston, Canada, at Queen's University, where I am based in currently. So in a nutshell, that is my journey from Kathmandu to Kingston.
Very nice. Very nice. So your cancer policy fellowship at Harvard, what prompted you to get to that policy fellowship and what did you learn out of it?
Well, it was a very meaningful fellowship for me. It was at the Portal Group under the mentorship of Professor Aaron Kesselheim. While I was doing my training in Japan, I had started to be cognizant of the fact that not everything in oncology is what it seems. For instance, drugs look shinier on manuscripts than when you actually use them. And I was also being aware of several policy issues in terms of regulatory policy, the role of regulators, the role of bodies like WHO, ASCO, ESMO, and the role of national formularies, national cancer control plans, the whole intersection of cancer policy and global oncology. I was getting interested in those domains, and I was already starting to do some research on those aspects. And then, as I mentioned, after my period in Japan, I went back to Nepal. I started working there as an oncologist. And while I was working there, of course, I did not have as much time as I used to have to dedicate to research and academics. I was more of a full-time clinician. And towards the end of my training in Japan, I was already in collaboration with the Portal Group at Harvard. We were doing a couple of projects together. And so while I was back in Nepal, I got offered this fellowship opportunity to go to Harvard and learn policy in more detail to become a better researcher, a better scientist, a better writer. And I thought that was a great opportunity. And, it was also easy to convince back home, saying that, I got a fellowship at Harvard. And
you can't deny that, right?
Yeah.
Very good, very good. So what is, just circling back to what you said, what is the role of WHO as we speak in terms of cancer management across the globe?
WHO is a big institution. There are many subsections and departments and units looking into different agenda. For example, they have a different unit looking into cancer prevention. There is a different unit looking into smoking and so on. The unit that I am most closely affiliated with and working with is the Essential Medicine List Committee. So the Essential Medicine List, it's not only for the cancer drugs, but the whole Essential Medicine List. So this committee's role or mandate is to ensure what drugs should be included in the Essential Medicine List and what should not. And as you can imagine, that takes a huge amount of exercise, because it's not only about the quality of evidence or the price, but it's also about thinking in terms of whether that is the most appropriate action plan for these countries around the world. Because it is very easy for us to say, Pembro should be an essential drug. Of course, like who would debate that? Yes, pembrolizumab is wonderful for so many cancers. But over there, I am also involved with some national and international regulators here in Canada. But the hat that I use when I'm at WHO is quite different, because over there, I'm not just looking into, is this trial well done? Is the quality of evidence solid? Is the magnitude of clinical benefit excellent? But also thinking in terms of, okay, if we're asking the governments to make pembrolizumab as an essential and always available medicine, where is that money coming from? Does that mean that children are not getting enough nutrition because that budget is now being taken by Pembro? Does that mean children are not getting education? Does it mean women are not getting cervical cancer vaccination? So those are quite intense intellectual exercises. And also because I come from the background of Nepal, it feels very real and palpable to me about those trade-off decisions. But to answer your question, I'm most closely working with the EML committee, Essential Medicine List Committee, and I think it has a big importance in that, although it's not a legal mandate, but it carries that political power. Like we released the new EML version like a month ago, so it was all over news. So every time a new Essential Medicine List version comes out, it is like a political pressure on the governments all over the world to make sure that those medicines that are deemed essential are actually available for the patients in those countries.
For the National Cancer Institute, the total national cancer expenditure just for the U.S. for the year 2020 is estimated to be around $208.9 billion. Obviously, that, is a lot of money. And so that kind of, pushes me to pivot towards our next question around financial toxicity, because you have had some interests around financial toxicity. How can we minimize that without impacting our outcomes?
Yeah, that's a great question. And US is in a very unique situation because the health system there is, you have better knowledge than I do about that, but the health system is super complicated. It's neither entirely publicly funded like Canada, nor completely out of pocket like Nepal. So it's somewhere in between. And there are certain groups of patients who suffer severe financial toxicity because of rising insurance premiums or significant out-of-pocket costs. And, there are some patients who might not face it as much. So there is a huge spectrum there. But in general, our cancer care expenditure is going out of hand. That is a reality. You cited this new number. Yeah, it has been around $200 billion for the last few years. And 10% of that is on cancer drugs alone. So $20 billion is for cancer drugs alone. We did a number of studies comparing US with other countries. We looked at the health technology assessment criteria for G7 countries plus Australia plus New Zealand. Of course, US does not have a health technology assessment body. So Medicare is forced to pay for every single drug that FDA approves. But we looked at these other countries, and many of these countries are not approving the cancer drugs that are best sellers in US. So the best-selling cancer medicines in the US, they're not even approved or funded in these other high-income countries. We are not talking about low-income countries here. Countries like Canada, Australia, New Zealand, they are not. They're spending only a fraction of what US is spending, because they are not spending on these drugs that are not improving outcomes. And there was one very interesting study published in JAMA Health Forum back in 2022, where they looked at cancer mortality outcomes with expenditure. And what they found was, just because a country spends more does not mean the cancer mortality rates are improving in those countries. So there was no correlation among high-income countries. Of course, there will be correlation if you look at LMIC versus high-income countries. But among comparable high-income countries, there was absolutely no correlation between cancer care expenditure and improvement in mortality rates from cancer. So just because we are spending more does not necessarily mean we are saving more lives or improving the longevity of the patients. That is something that we need to keep in mind. And of course, in terms of health system, if we want to protect our system from financial toxicity can happen at different levels. There is a system level toxicity and there is a patient and family level toxicity. At systems level, if we want to save our health systems, then of course we need to curtail our spending on wasteful cancer drugs. And there are so many examples of this. I recently, like a week ago, published a paper called Cost of Convenience in Cancer Care. So sometimes we are spending on things that does not even make any sense. For instance, I'm going to take names now. I'm going to name names. For prostate cancer treatment, we have this GnRH agonist and antagonist, like degarelix, for instance, GnRH antagonist, or leuprolide or goserelin, whatever you want to use. These are injections. These are not oral. These are injections, but you have formulations that can be given every 3 months. You have formulations that can even be given every 6 months. And then there is this new guy called relugolix, and it's oral. And now, if you look at it does exactly the same thing. It's also a GnRH antagonist. Relugolix is just oral version of degarelix. Now, if you look at the price difference, it's mind-blowing. Like per month, if you calculate in terms of per month, it's $500 versus $3,000, right? And what do you get by spending $3,000 instead of $500? Nothing. It does the same thing. And why is this new drug even being priced at $3,000? Because they can, A. And B, why are people even using it? Because they are selling that it's oral, so it's more convenient for the patient. I think it's ridiculous because I think I would rather have one injection every 6 months than remember to have pills every single day. So it's not even convenient in that sense. But they're claiming that it is more convenient because it is oral, so they can be priced higher. So just throwing out one example of what we are paying for. Is that going to improve outcomes? Of course not. But we're happy to pay so much extra money just for the sake of it being convenient, which in fact it is not. And then there are several other examples of drugs improving survival by a few weeks, and many other drugs that don't even improve survival. It's clear that these drugs do not improve survival, do not improve quality of life. And we are using these drugs simply because it makes us feel better that the scan report comes as progression only 2 months later. That's all it does. It delays progression by 2 months. It does not improve quality of life. It does not improve survival. So when we are spending so much on these drugs, then of course the data will continue to show that we are not getting enough return on our investment. And there are countries who do far better by allocating those financial resources to other high impact interventions. Now, at a patient level, it becomes more complicated. At a patient level, there will be patients who will suffer very severe consequences. Like we are talking about United States, there is high quality data now, consistent data showing that financial toxicity is associated with lack of adherence to treatment, bankruptcy, and even increased mortality and poor quality of life. I think one thing that people need to get it clear is that when we talk about financial toxicity, this is not just about a socio-political economic issue. It is a real clinical issue. Like the way you worry about pneumonitis, you should also worry about financial toxicity because both are killing patients. Both are leading to poor quality of life. So it is a clinical issue. If you worry about dermatitis, you have to worry about financial toxicity. Because people are dying from this, people are having a poor quality of life. But how do we mitigate that? Now that becomes a bigger problem. So for that, I think we need to start at institutional level, at government level, and even international society level, like big ASCO, ESMO, and so organizations. And at a guidelines level, guidelines should stop recommending these wasteful drugs without clear evidence of benefit. At institutional level, there is even lack of price transparency. For instance, in most US hospitals, you correct me if I'm wrong, but if a patient comes to your clinic and you have offer of, do you want to get durvalumab or atezolizumab, they have absolutely no idea what their out-of-pocket cost is going to be for option A versus option B.
Right.
So there are things that we can easily fix. And there are also things that need fixing at a much larger, higher level.
Absolutely. So such great topics and points that you mentioned, and also, in the US, the other problem is that if you get the same drug in a clinic outpatient setting versus you get the same drug in an inpatient setting or in a hospital setting, even though there is a clinic attached to the hospital, there's a difference in the price cost. So there's lack of transparency for sure. We have cancer moonshot here in the US, Bishal, but you coined the term cancer groundshot. What does cancer groundshot mean?
Yeah, so it's, I think, a pretty simple concept, but important. In that, on one hand, you want to discover more and more drugs, newer innovations, newer technologies. And I'm not discounting that. It is important. But if those innovations, technologies, drugs, if they do not reach patients, do they save lives? Like, you don't save lives just by having a product. The product needs to reach people who will benefit from it. And the reality is, if you look at data right now, most cancer patients in the world, they die not because they don't have access to these fancy new molecules. They're dying because they don't have access to classical proven interventions that have been proven hundreds of years ago. Like, they don't have access to surgical facilities. They don't have access to radiotherapy machines. There are still many countries in the world without a single radiotherapy machine. They don't have access to pain control. There is not enough morphine in many countries. So when people in the world are dying because of lack of access to proven interventions that we have shown to improve lives hundreds of years ago, how are we going to address the problem of global cancer burden just by discovering new molecules? In one of my papers, this was back in 2015, 2016 is when I was young. I wrote in Journal of Global Oncology a commentary called Me Too. And at that time, the fanciest new drug was palbociclib. Now, it does not even come in the top 20 list of fancy drugs. At the time, the fanciest drug was palbociclib. And I still remember a sentence that I wrote in that paper because I was, giving the perspective of someone practicing in Nepal. So I wrote that the discovery of palbociclib in breast cancer is similar to the discovery of black holes, right? Very exciting from scientific point of view, but practically meaningless. Like, we won't be able to use that drug for next 10 years. So if someone tells me, oh, we found a new black hole in this part of the universe, I'm like, okay, very exciting. But how am I going to use the data for my, so similarly, you say that, okay, CAR T is amazing. It is like discovery of black hole to many patients in the world, to majority of patients in the world. So cancer groundshot is a philosophy that proposes that we need to invest equally, or at least give a fraction of the moonshot budget, right, to implement on things that have already been proven to work. So yes, continue to develop new things, new technologies, but at least invest a certain percentage of that resources to help implement the interventions that have already been proven to work. So if we cannot improve the fidelity of the implementation of the interventions, then just discovering one and another new molecule is not going to improve outcomes at a population level. So that is fundamentally what cancer groundshot is. To give a real life example, when I interact with colleagues from policy colleagues from LMICs, sometimes I hear things like, yeah, cervical cancer is a big problem in our country, but we don't have access to Pembro. And, that should be our goal. And I'm like, for the cost of Pembro for 100 patients for 1 year, we could run HPV vaccination campaign in the whole country and probably even do cervical cancer screening. And HPV vaccination rates are very poor in that country. Cervical cancer screening is almost non-existent. But the policy level discussion is revolving around dostarlimab and pembrolizumab for cervical cancer. That is quite upside down in my opinion. So yes, finding that dostarlimab, pembrolizumab are helpful in cervical cancer is important. It is moonshot. But what about the groundshot of making sure that women don't even have metastatic cervical cancer in the first place? Like in 2025, no women should be dying of cervical cancer. If there is only one cancer that you can claim as we can prevent it, it is cervical cancer. We can prevent it. Why should anyone even need dostarlimab? They should not be having metastatic cancer in the first place.
It's high time we have a reality check in medicine, right? Not just in cancer care, but everywhere. I think we're complicating things more than they need to be complex, right? So that's absolutely correct. And that kind of brings me to my next question, Vishal. I chat GPT'd common sense because I wanted to give it a beautiful definition, right? So, common sense is the basic ability to perceive, understand, and judge things in a practical, straightforward way that most people would agree is reasonable. You, my friend, have started Common Sense Oncology. Tell us about it and what was your vision and mission behind this?
Yeah, no, no, that was a very good definition by ChatGPT. We are going back to the fundamentals. So fundamentally, when we are using a cancer drug, when we are prescribing a cancer therapy to the patient, why would the patient, like all cancer therapies have toxicities, right? So why does a patient accept that toxicity? What is the trade-off there? So any patient who says, okay, I'll undertake this treatment, I'll undertake this chemo, yes, the list of side effects sound horrendous and I might die, but I'll still take a chance and I'll take this medication. Why? Because if I take the medication, probably I'll have a longer life and a better life compared to not taking the medication. That's the whole equation, right? Like there is nothing else. I get toxicities, but I accept that because in trade-off of those toxicities, probably I'll have a longer and a better life. Ideally both. If not longer and better, at least one of them, or longer or better. But most of our drugs don't have evidence that they do either of these. No evidence for improving quality of life, no evidence for improving survival. And so when we talk about this, that our drugs should have this evidence of longer life and better lives, we thought it is common sense that cancer patients should have a longer and better life as a result of taking these medications. Otherwise, why are we spending so much on these medications? Why are we offering so much toxicities from these medications? They should live longer and better. That sounded very common sense to us. But for some people, it sounded very revolutionary. Oh my God, you want cancer drugs to improve survival? We just wanted to shrink the tumor. But does shrinking the tumor lead to longer life? No. Does shrinking the tumor necessarily improve quality of life? No. Then why does it matter whether the cancer is 5 centimeter or 4 centimeter? So in 2022, I guess, Chris Booth, who is my colleague, mentor, and we work together, we wrote a paper in Nature Medicine titled Common Sense Revolution in Oncology. And we were playing a satire on that because we think it is common sense. People think it is revolution. So we said it's a common sense revolution in oncology, that cancer drugs should extend lives, improve lives. It's a common sense revolution in oncology. And we published that paper. And I'm really proud of that paper. In that paper, we fundamentally outline our vision. But at that time, it was just a paper. And then we started to discuss, Chris, we have written so many papers. Like he has written so many papers. I have written so many papers talking about these issues. And it is not just us, like many people before us, like Ian Tannock, Elizabeth Eisenhower. So many people have written about these issues. We don't see any substantial change happening. It's not like it has all been futile. We see that many trainees and young oncologists are more aware of these issues than they used to be in the past. People are questioning these things more now than they used to in the past. So, but still, like are we just going to write papers and hope that someone will read them and make a difference? Like how many papers, I'm not bragging, but I think I have now like 230, 240 papers. Like if I publish 50 more papers, am I going to make a difference in the world? Probably not, right? Like it's not about how many papers you have. At the end of the day, irrespective of how many papers you have or you do not have, the question is, did I contribute to a meaningful solution? Did I contribute to having a positive difference? And of course, my papers have contributed. I'm not discounting the importance of my papers. I think they are all important and they have made a meaningful difference on the place. But we wanted to do something more beyond writing papers. And we thought, okay, let's do something about it. Yeah, every time you have some conversation over a couple of beers, you get these crazy ideas. And it was one of those crazy ideas, which we thought it was crazy, but we were like, okay, let's try it out. And the first thing we did was we sent email to a bunch of people who we thought were going to respond to us saying, you guys are crazy, this is a crazy idea. But all of them responded saying, this is an amazing idea. We always wanted someone to do this. Thanks for taking this initiative. We're all in. And then in 2023, we had our first inaugural meeting of Common Sense Oncology in Kingston, Ontario, where we are based. And it was a meeting of almost 25 to 30 people. We could not gather more than that because we even did not know what it was going to shape up to be like. We needed like a manifesto. What is our vision going to be like? What is our mission? What are our guiding principles and so on? So this represented a diverse group of people, physicians from medical oncology, radiation oncology, journal editors, patients, advocates. We wanted to have a mix from low-income countries, high-income countries. So we came here in Kingston and we drafted our manifesto, which was published in Sense Oncology, our first Common Sense Oncology paper, which contains our vision, mission, principles, and everything. And since then, it has taken off quite well, I should say, like far beyond our expectations, because in our website, almost 3,000 people from all over the world have signed up to become members. We are hosting events at ASCO, ESMO. We host regular webinars. One of our biggest product has been the Common Sense Oncology checklist for designing and reporting RCTF cancer drugs, which was published in April of this year. And this checklist has been modified for the use by the discussant of plenary sessions of this big meeting. So I think we have made quite substantial progress, but of course we always want more. So it has become like a full-time job in itself. So it almost feels like I have 3 or 4 full-time jobs: so Common Sense Oncology, clinical work, academics, and teaching. But yeah, it has taken off quite well, and we are very pleased with the reception that we have gotten from people all over the world. And one important thing that I love about this is, of course, we have several things that we are working on. That's separate, but separate from all of that, the thing that I feel most deeply passionate about is the effect it has on trainees and young people and early career people and people from low income countries. Because one of the things for the young or the early career people is having a role model, right? Like if you are an early career oncologist, then I guess your goal would be, oh, one day I need to be on the plenary stage. I want to be the first author of a New England publication, of a Lancet publication. So everybody has grown up just looking at those classic role models. And I think our group of people are offering trainees and early career oncologists an alternative career path. They can, an alternative role models. They can look at, people like Ian Tanner, Chris Booth, and Elizabeth Eisenhower, and so many people in our group, and they can have a dream that, okay, one day I'll become like them. It does not always have to be I'll become a first author on a phase 3 clinical trial that was funded by the industry, written by the industry, slides were prepared by the industry, and I'll just go on the stage and read those slides. So that role modeling or inspiring the new generation has been something that I feel very passionate about. And the other thing is, I talked about international oncologists, global oncologists. Several times we hear comments like, I was speaking with a colleague from Chile, for instance, and this has been a very common theme when speaking with people from different low-income countries. For instance, olaparib for pancreatic cancer. And just giving random examples. I don't have anything specific against any of these drugs. And they would say things to the effect that we were, it was published in New England Journal, and our SDA body or our oncology society was considering if we should make this drug available in our country, but it was very expensive, so we are not sure what to do. Then we read your paper, then we listened to your talk, or we saw this being spoken at a Common Sense Oncology seminar, and we now understand that our money is better spent on something else. and we saved our health system from millions of dollars from being wasted on a futile drug in a futile setting. So that sort of validation, especially in low-income countries where you don't have access to every single drug, and probably you don't want to feel like, oh, in US, US oncologists are prescribing this and that. I wish I had access to that. But then they listen to some of our colleagues who, despite practicing in US or Canada or whatever, they are recommending against the use of these drugs, and then they feel sort of validation that, okay, it's not just us because of lack of access. Even if you had access, probably you would not have wanted to use this. So those sort of small things, like inspiring the younger generation, providing them with role models, and collaborating with colleagues from LMICs on these issues, those give me the biggest satisfaction.
I think the other group that would really derive a lot of benefit from Common Sense Oncology is just a simple community oncologist here in the States, because I'm a community oncologist. I have a lot of rural population as my patients too. So we always don't have access. I mean, olaparib, palbociclib, we obviously have access. We use them right and left. But there are drugs that, can be heavily used in bigger centers, but we don't have access to those drugs. So I think we practice Common Sense Oncology too.
No, absolutely. And we talk about global oncology, but there is a global oncology in our own backyard, right? Like there are pockets of population in US, pockets of population in Canada, whose cancer outcomes are worse than the outcomes of patients in LMICs. So there is a huge disparity within the high-income countries as well.
Right. Absolutely. Yeah. All right, Bishal, on to the next question. One advice you would give to yourself of 10 years ago.
I guess I would have told myself that, take it easy, dude. Everything is going to sort out by itself. Don't worry too much. Because, I have made so many transitions in my life, and at every moment, those transitions seem scary, right? Things will make sense only retrospectively. Things will never make sense prospectively. Prospectively, it's just a leap of faith.
Right.
Should I go to Japan? Who knows? Nobody will have an answer for me.
Right.
I just go and see and figure things out. If it does not work out, I'll try to fix it. If it works out, fine. Things will make sense only retrospectively. When I finished my training in Japan, what should I do? Should I go back to Nepal? Who knows? What is the right decision? You can't have a counterfactual for your own life because you can't randomize yourself into a clone. So there is no comparison there. There is no control out there. So I would have told myself, take it easy. Don't worry about what's going to happen in the future. Things will sort out by itself.
Absolutely. Beautiful.
Just do your best for the immediate next step. We can only see what the next step will be. You can't see from here what the next 10th step will be.
All right, Vishal, a little bit of rapid fire about you. Your favorite book?
Surely you are joking, Mr. Feynman. So I'm a bit of background. I'm big into physics. I love physics. If I was not a physician, I would have been a theoretical physicist. And Feynman is a physicist who has deeply influenced and shaped my thoughts. So it's his autobiography. Surely you are joking, Mr. Feynman.
Yeah. Got it. Your favorite leader then?
Leader, as in political leader.
It can be a healthcare leader, political leader, anybody who has influenced you. It could be your boss. It could be your mentor.
Okay, then I'll take the name of Ian Tarak.
Yeah. I think you guys were mentioning him at our IAC recently too, right? Yeah. Your favorite cancer study?
Oh, God. My favorite cancer study. There are many, and that there are plenty, but because this is the most recent one and it's fresh in my memory, I have conflict of interest here. It's Chris Booth's study, so the exercise trial.
For sure. It made a lot of buzz. We were just talking about it in clinic yesterday.
Yeah.
Okay, your favorite restaurant in Kingston, Canada?
Okay, again, I have conflict of interest, but my friends have just opened up a new, or the first Nepali restaurant in Kingston. It's called Hakka Himalaya.
Okay.
So yeah, it's my friend's restaurant. So it's a conflict of interest.
Beautiful.
But there you go.
Well, you come with full disclaimer, so that's fine. All right, Bishal, one fun fact about you. I'm sure there are many.
One fun. Okay, I'll give it two. One is I learned how to swim by watching YouTube videos. I did not, no swim teacher because I was embarrassed at my age to learn swimming. So I learned how to swim by watching YouTube videos.
What age did you learn swimming at?
At the age of when I moved to Canada. So that in 2019. So that would be, people will know my age. So 6 years ago.
Okay. All right. Fair enough.
The second one, I saved the lives of 2 professors of oncology from my institution in Mozambique. They were about to get arrested.
Ah,
So that is
wow. How so? Maybe you can tell me more offline.
this is a very funny story.
Yeah, well, let's talk about it offline then. All right. If you were to relive your life, Vishal, would you become an oncologist? This is your last question of the day.
If I were to relive my life, I would not change any single thing that has happened to me, both the good things and the bad things, because the collection of, I'm not saying that my life has been easy, far from it. My life has been difficult, but I will not change a single thing, because the collection of all those experiences, events, has brought me where I am today. So I will not change a single thing.
Very good. Very good. Well, thank you, Vishal. 3 key takeaways for the oncology community from Dr. Bishal Gyawali. Number 1, financial toxicity, folks, is a critical issue. And I think we need to start putting our efforts into research around how financial toxicity is actually impacting our patient directly in the clinic, right? So it is impacting quality of life, mortality, not just in the LMICs, but also in the high-income countries as well. So I think it should be part of our curriculum to understand the finances of the drugs we are using, or even, other stuff like imaging and lab tests, etc., and how frequently we are getting tumor markers, etc. I think all of that adds to the cost. Number 2, I love the Groundshot term that Dr. Gyawali has coined. It's really coming down to the access issue and access to the simple art of medicine and surgery, right? So, of course, it can take a lot of effort around policy to get the latest advances, not just in the LMICs, but also in the high-income countries, in rural areas and remote areas. But the plain, simple medicine and surgery patients should have access to those avenues of medicine. And last but not the least, I think I want to be a part of Common Sense Oncology, Bishal. Right?
No, yeah, I think you already are.
Yeah, I think we as community oncologists, see so much of this in our clinics every day, and I think a lot of the principles you guys are striving for is what we strive for in our clinics on a daily basis, or in our advocacy visits, etc. So I think I feel like the word is common sense, but I think we have to be intentional about pursuing the common sense oncology. There is a campaign called Choosing Wisely within the states, which we do follow, and I really like those principles. But I think we need to get better at it. So that's all for today, folks. Thank you to our viewers and listeners. This is Jasmine Kamboj and Bishal Gyawali signing off on behalf of OncoDaily from our conversation on Empowering Oncologists. And now we have a playlist on YouTube, so don't miss an episode and stay tuned. Thank you, Dr. Gyawali. Thank you so much.
Thank you very much. Bye.
Bye.
Don't forget to like, comment, share, and subscribe to OncoDaily on YouTube. Hit the bell icon to stay updated.